Our next speaker is Dr. Niluka Paththinige. She is currently working at General Hospital Monaragala. She will be discussing with case-based clinical pearls. Over to you.
Right. Thank you, madam, for that kind introduction. Good afternoon, my dear teachers and colleagues. Today my topic is case-based clinical pearls. Sorry about that. Okay. So I chose this topic to discuss some interesting cases which I came across during my overseas training. I thought it's worthwhile to share it with you all rather than discussing one topic. So I did my overseas training in Sydney, Australia, and I worked at the St. George Hospital with Professor Didi Murrell and Dr. Ben Daniel. During that training, I had wide exposure to clinical dermatology, and I got advantage of working as an investigator for many clinical trials, phase 2, 3, and 4. So coming back to the topic, case-based clinical pearls. So this is the pearl one. She's Mrs. J, 45-year-old Australian lady, who's having Hailey-Hailey disease for last 16 years duration. And her main sites involved were bilateral axillae, groin, submammary region, abdomen, and few areas of her back. So she was diagnosed with Hailey-Hailey disease with typical histopathology. That was long years ago. And during that period, she was on many treatment options in addition to preventative measures. As mentioned here, she was on topical corticosteroids, topical antibiotics, topical tacrolimus, and many courses of short and long courses of oral antibiotics. So in spite of these conventional treatment, she didn't get any successful resolution for her disease. Her background history was prominent for stage 3 chronic kidney disease, hypothyroidism, and post-traumatic stress disorder. And her renal physician thought chronic kidney disease can't be due to any other cause. It's due to these many causes of long-term oral antibiotics because she didn't have any background history of diabetes, ischemic heart disease, renal calculi, or exposure to renal toxins, or any family history of chronic kidney disease. So she was currently on these medications, levothyroxine, citalopram, and medroxyprogesterone for contraception. And on examination, as you all can see here, she had symmetrical distribution of erosions with crusting and peeling of her skin of both axillae, submammary region, groins, abdomen, as well as few areas over back. And her pain score was 9 out of 10, and dermatology life quality index was 26 out of 30, and her hospitality, anxiety, and depression score was 29 out of 42. So she was suffering from disease a lot. So since the patient didn't have any positive response to all the conventional treatment, we had to look for alternative options for this patient. So when we look into the literature, we found that low-dose naltrexone has successful results in recalcitrant Hailey-Hailey disease. And there were many case reports and small case series. So these are 2 out of those case reports. And the last one was published 4 months ago. That was after our patient's treatment. So based on these reports, we started our patient on oral naltrexone, 1.5 milligram daily, continued for 2 weeks. From 3rd week onwards, we increased it to 1.5 milligram twice daily. Then from 5th week onwards, 1.5 milligram 3 times daily. Then 7th week onwards, she was on 2.5 milligram twice a day. So this was commenced after seeking clearance from her renal physician because she had a background history of chronic kidney disease. But at that time, fortunately, her renal physician told all her renal functions were normal, so there were no restriction to start any other treatment. And we had to have a lengthy discussion with the patient because this is not a recommended treatment for Hailey-Hailey disease, and this is an off-label treatment, so we had to have a lot of discussion with the patient before starting the treatment. So her baseline investigations were normal. We started her on treatment, and while on treatment, we monitored her renal and liver functions monthly. So as we expected, she started to show a good clinical response after 2 weeks of treatment. And these pictures after 2 months of treatment, which she showed complete remission. So A and B before starting treatment, and C and D 2 months after the treatment. So this was very impressive, and the patient was also so happy, and her scores were improved after the treatment. And her post-traumatic stress disorder was also related to her disease because she lost her job because of her disease. So again, after control of the disease, she again regained her job. So she was off treatment for post-traumatic stress disorder as well. So as we all know, Hailey-Hailey disease is an uncommon autosomal dominant disorder in which mutation in the ATP2C1 gene result in dysfunction of the Golgi-associated calcium ATPase, interfering with intracellular calcium signaling. Although it's not a life-threatening disease, patients are suffering a lot. So it's have a significant negative impact on patients' quality of life. So how does naltrexone work in Hailey-Hailey disease? It's not fully proven, but it's suggested that naltrexone is having antagonistic effect on the mu and delta receptors in basal keratinocytes, and it affects toll-like receptors, leading to diminution of pro-inflammatory cytokines and changes in intracellular calcium metabolism. So this increased cellular adhesion and expedite the healing of skin lesions. So with this background, I tried this treatment in one of my patients at Monaragala. He's a 49-year-old gentleman who's suffering from Hailey-Hailey disease for last 20 years duration without any satisfactory improvement for the normal treatment. So initial picture and the third picture showed disease status before starting oral naltrexone, and the second and third picture shows disease condition 2 months after starting oral naltrexone. Again, I started with a small dose, 1.5 milligram nocte, increased to 1.5 milligram twice daily from third week onwards, then increased to 1.5 milligram TDS from fifth week onwards. Now he is on 2.5 milligram BD with very well control of the disease. And you all can appreciate the complete resolution of the perianal lesions and 80% improvement of the groin lesions. So what are the learning points from this case? We need to search for new treatment options when our patients are not responding to conventional treatment. And trial of off-label treatment is not easy. It's very challenging because we need to have a lot of discussion with the patient since it's an off-label treatment. And we need to discuss with relevant physicians if patient is having other comorbidities if we are starting on a new treatment. And we need to monitor the patient closely for possible adverse effects as well as clinical response to decide whether we need to continue the treatment or to stop the treatment. And it's interesting, oral naltrexone is freely available and it's very cost effective. So it's a very low cost, low risk alternative or adjunct treatment for patients with Hailey-Hailey disease who are resistant for the conventional treatment. And the main practical problem is naltrexone is available only in 50 milligram tablets. So we might have to compound it before giving small doses. So we need to discuss with the pharmacist to compound it before issuing the small doses. I'll move on to the next case, Pearl number 2. She's a wheelchair-bound 69-year-old lady who's suffering from multiple sclerosis with permanent disability for last 35 years duration. And she presented with 2-month history of generalized pruritus, erythema, followed by tense blistering. So what would be the clinical diagnosis for this patient? So it's bullous pemphigoid with background history of multiple sclerosis. When an elderly lady presenting with these typical features, we need to think bullous pemphigoid as our first differential diagnosis. So our patient was diagnosed as bullous pemphigoid with typical histopathology and immunohistochemistry studies. And we had a separate dedicated bullous clinic twice a month. So we used to score each and every patient, every new patient and follow-up patient with relevant score system. So for this patient, we scored with bullous pemphigoid disease activity index, which had active score of 50 and damage score of 8. And her bullous pemphigoid pruritus score was 25 out of 30. And autoimmune bullous skin disorder intensity score was 52.75. So we started her on normal treatment, prednisolone 0.3 per 3 milligram per kg since she was elderly and she is suffering from disability due to multiple sclerosis. In addition, we started her on doxycycline 100 milligram twice daily with nicotinamide 500 milligram twice daily. The prednisolone was tapered over 9 months after initial consolidation phase, and other treatments were continued. In spite of this, she had significant remained erythema, but patient didn't want to go back to prednisolone. So we had to think about alternative treatment in combination with bullous pemphigoid and multiple sclerosis. And we all know that dimethyl fumarate is an oral small molecule immune modulator, and it's already licensed to treat psoriasis and multiple sclerosis. And mode of action of dimethyl fumarate in multiple sclerosis is not very well described, but it mentioned it has a potential to reduce the activity and impact of inflammatory cells on the central nervous system and induce direct cytoprotective responses in CNS cells. So dimethyl furanate shown to be effective in treating epidermolysis bullosa acquisita in a murine model in a research, and the same study showed that it's effective to reduce blisters and other symptoms by reducing the inflammation in bullous pemphigoid, so which can control the disease of bullous pemphigoid. And we know multiple sclerosis is strongly associated with bullous pemphigoid, and it's a recommended treatment for multiple sclerosis. But unfortunately, since this patient had permanent disability due to multiple sclerosis, it was not issued from the government. So, because she had permanent disability, and usual indication is relapsing remitting multiple sclerosis. So we had to take a government clearance by proving this patient is having bullous pemphigoid and these two diseases are strongly associated. Then we can get the drug from the compassionate supply. So dimethyl fumarate was added to a treatment starting with a 120 milligram twice daily for 7 days. Then it was increased to 240 milligram twice daily. 1 year after first presentation, that was about 3 to 4 months of starting of dimethyl fumarate, we were able to omit all the other treatment like nicotinamide and doxycycline, and patient was continued with dimethyl fumarate 240 milligram BD for another 1 year. And this showed her improvement of the disease with scoring system. So BPDI score at presentation was 50, and before starting dimethyl fumarate, since she had this prominent erythema, it was activity was 0, but damage score was 8, and abscess score was 14.5. So 1 year after startment of the dimethyl fumarate, her BPDI activity score went down to 0, and pruritus score was also 0, and abscess score also went down to 0. So this case was published as the first patient treated with bullous pemphigoid patient treated with dimethyl fumarate with successful improvement. Then I'll move on to the learning points from this case. So we know multiple sclerosis is one of the most common concomitant neurological condition associated with BP, and the usual treatment of bullous pemphigoid is corticosteroids, which is detrimental in elderly people because most of the patients affected by bullous pemphigoid are elderly people. There are alternative treatment like doxycycline, nicotinamide, dapsone, but there are research that dimethyl fumarate effective in epidermolysis bullosa acquisita, and it has shown effectiveness bullous pemphigoid. So when a patient comes with combination of multiple sclerosis or the neurological condition with the bullous pemphigoid, we can consider dimethyl fumarate as a treatment option. And other than this, we need to think of newer treatments for bullous pemphigoid to minimize the detrimental adverse effects of steroids in elderly. Pearl number 3. This is an 85-year-old male with a history of multiple myeloma, presented with an asymptomatic reddish plaque over the right calf for 3 months duration. He had been on long-term chemotherapy, and he was in remission for 5 years with regard to multiple myeloma. And dermatological examination revealed a pinkish to erythematous firm indurated plaque over upper right medial calf as shown here. So what is the clinical diagnosis? With typical clinical features with a background history of multiple sclerosis, we had to consider secondary cutaneous plasmacytoma as our first differential diagnosis. So we took punch biopsies and sent for histopathology and immunohistochemistry. And these are the results. Histopathology showed widespread infiltration of the dermis by uniform population of intermediate to large cell size atypical cells with plasmacytoid morphology, proving cutaneous plasmacytoma. And the immunohistochemistry studies showed positivity for CD138, which is very specific for secondary cutaneous plasmacytoma. And CD20, CD39A, CD3, and cytokeratins were negative. So the final diagnosis made as secondary cutaneous plasmacytoma in the setting of multiple myeloma. And CD138 is important mentioning, it's a specific marker for plasma cells within the bone marrow of patients with multiple myeloma, and it may be important for plasma cell anchoring in the bone marrow. So if we found CD138 in a biopsy sample, it proves that it's secondary cutaneous plasmacytoma, secondary to multiple myeloma. Unfortunately, our patient passed away 8 months after the diagnosis of this, and he was refractory to chemotherapy. So cutaneous manifestations of multiple myeloma can be specific or non-specific. The most specific cutaneous finding is cutaneous plasmacytoma, and it's very rare. And other non-specific manifestations are scleromyxedema, xanthomas, hyperkeratotic specules, amyloidosis, pyoderma gangrenosum, Sweet syndrome, leukocytoclastic vasculitis, and other vesicular disorders. So what are the learning points from this patient? Plasmacytoma of skin is very rare, but we need to consider the relevant diagnosis in the given setup. And we can prove our diagnosis with typical histopathology and immunohistochemistry. And secondary cutaneous plasmacytoma is a bad prognostic marker. It was proven in the literature. So in this case, it was an important clue of the prognosis of the disease. And in future, it's very important to diagnose this urgently, because some patient may be in remission, but they can go into aggressive disease immediately. So it's very important to diagnose the aggressive nature of the disease and to start treatment promptly to save the patient. Thank you so much.
Thank you, Niluka, to sharing these interesting cases with us. There's time for questions.
Thank you, Niluka. That's very interesting.
Thank you.
Can I ask one practical question?
Yeah.
About compounding the
Naltrexone.
Like because you have to bring it down to a very low dose from
Yeah.
50 to...
At Monaragala, it was not available in the hospital. So I discussed with the state pharmaceutical company. So they agreed to compound it. So it took about, few hours.
Right.
So they compounded it like into small sachets, 1.5 milligram sachets. So we used to issue for 3 weeks duration, like then patient need to again go back to the SPC to get the samples.
Okay, thank you.